have her coming here. I met her last year at a pain meeting, and her talk was just so amazing that everybody should hear it. Dr. Savage graduated from Dartmouth Medical School, and she's currently board certified for pain management, pain medicine, addiction medicine, and she's also a fellow of the American Society of Addiction Medicine. She's the medical director of the Chronic Pain and Recovery Center at the Silver Hill Hospital in Connecticut, and also served as the advisor to the Dartmouth-Hitchcock Health System substance and pain-related education practice improvement. And Dr. Savage also has an academic position at a Dartmouth Anesthesiology department. She has been consulting, served as a consultant on many national organizations, and many of you probably know she was the president for American Pain Society from 2010 to 2012. She served New Hampshire Governor's Commission on Alcohol and Other Drugs, and is currently co-chair for the Commission's Task Force on Opioid and Healthcare. She's also the co-chair of the Chronic Pain Work Group of the Federal Pain Research Strategy, which is led by NIH for developing priorities for pain research. So without further ado, please.
Thank you so much for that nice introduction. I have done a lot, but it's primarily because I've been around for a very long time. And you will find over the course of your careers, I imagine that it's not the straight path that you might think it will be. If you have a lot of curiosity, you likely will start out looking at one thing and it will lead you to places that you really can't imagine. So I did start out as an anesthesiology pain medicine physician, and over time, so I was a lot in the OR and doing blocks and interventionalist procedures and really looking at pain as a primarily physiologically hardwired kind of experience that people have based in the physiology of pain. But over time, I became really fascinated by how pain can change from day to day within one person, how people with really serious progressive tissue pathology can have very limited pain, and other people with pathology that we can't even identify can suffer enormously with pain. So I've become increasingly interested over the course of my career in the biopsychosocial model of pain, and I'm going to talk a lot about that today. But we also, I understood that there was some interest in cannabis and how it's used in medicine, and also opioids because they've created such a problem. And my interest in opioids also evolved similar to the biopsychosocial interest because I kept encountering people in the context of pain treatment who, instead of getting better, a subset of patients would always get worse, and some would come to harm related to opioids. So more and more, I think, for people who are interested in pain, and I would encourage anybody, whatever field you're going into, it will be unlikely that your patients will not need to deal with pain. And sometimes it will become your responsibility to help them address that. So my talk today is really very clinically oriented and just some of the considerations when you're dealing with pain. It sounds like you have some excellent researchers here, and I'm certain that you get the neurobiology and the cellular mechanisms in the course of time. So I'm going to talk a little more about clinical issues, and I'm also going to talk a bit about substance misuse in that context, because that similarly, no matter what field you go into as physicians, whether it's surgery or psychiatry or internal medicine, you will have patients who not only have pain, but others and or some of the same people who also have substance use disorders. And it's exciting that you seem to be addressing these issues in the curriculum here, because until recently, most medical schools have not, and nursing schools and pharmacy schools have not talked a lot about either pain or about addictive disorders, and clearly both cause a lot of challenges in our patients. So I have no commercial relationships. I'm going to break my talk in a little bit to the experience of pain, what that is, just a little bit on mechanisms, and then talk about treatment of pain. What are the tools that we have available? But I'm going to focus on chronic pain and the role of self-management in chronic pain, though it can be very helpful as well in acute pain treatment settings. And then we'll talk briefly about opioids and briefly about herbal cannabis, which we need to be able to deal with. So the experience of pain. Most of us have had pain. Most of us have a sense of what pain is. But our earlier understanding of pain, starting in the 1600s, really, René Descartes, who was a philosopher and a neurobiologist of his time, thought a lot about the issue of pain. And this is really his vision that he was one of the first people to describe. Before that, pain was something that you experienced. It was bestowed on you because of behaviors or karma or something outside yourself. And he recognized that if you had a stimulus that affected the body, that was intense enough, it could trigger a pain signal that then went along these pathways, along the nerve fibers, up the spinal cord to the brain. And at that time, what we understood was simply the worse the insult to the periphery, the worse the experience of pain. But our understanding of pain has become far, far more complicated. And you likely will learn about this in your physiology classes. I'm going to touch very, very lightly on it here. Only to note, just to orient you here, we have a little digit that's been injured. It's bloody, it's been cut. And then nerve fibers that go to a cross-section of the spinal cord here, the butterfly inside the oval, being a cross-section of the spinal cord with the dorsal horn then. And then the signal going up the spinal cord to multiple synapses within the brain with multiple different brain centers. So in the periphery, we have transduction of what is fundamentally an electrical signal that's caused by intense stimulus of whatever kind, and then travels along the peripheral nerves to synapse onto secondary neurons in the spinal cord, up the spinal cord, transmitted to the brain and onto perception. So that's pretty much the René Descartes construct. But what we know now that is so different from that is that at every point along the way, there can be modulation of that electrophysiologic signal. In the periphery, there are many things that can modulate it: the presence of hydrogen ions, acidosis, lack of oxygen, hypoxemia, the presence of certain neurotransmitters, presence of prostaglandins, which can facilitate, and antiprostaglandin activities such as nonsteroidal anti-inflammatories can inhibit transduction of that signal. So at the level of transduction, many, many things can increase, decrease the ease of transduction or increase the ease of transduction. Then when that signal gets to the spinal cord, various neurotransmitters that are present can either inhibit transmission, or such as norepinephrine or serotonin, the basis for which we use tricyclic antidepressants, and duloxetine and certain other types of antidepressants that cause more availability of those neurotransmitters which are inhibitory, or glutamate, stimulation of NMDA receptors, that's a typo, it's not MDMA, it's NMDA receptors, facilitate transmission of pain. So we know, for example, and one of the things we'll touch on briefly is opioid-induced hyperalgesia that we're beginning to study and note clinically in some patients that seems to be caused either by changes in inflammatory processes in the spine, and I know that's being studied here, or possibly by stimulation of NMDA or facilitatory neurotransmitters in the spine. So modulation at the level of the spine is very important, and there is, the brain can send signals that inhibit at the level of the spine as well. And then finally, very importantly for clinical practice, when this signal gets to the level of the brain, there are rich interconnections with other brain centers, so that thoughts, feelings, memories seem to be able to impact the individual's experience of pain. And we see that clinically frequently, and it's one of the bases on which we know that working with patients in psychobehavioral interventions can have a profound effect not only in the experience of pain but on the quality of life. We also know that once the injury, the tissue injury heals, Patients can continue to experience pain because of ongoing mechanisms within the pathways that transmit pain. And there are multiple different types of neuropathic pain, and I know that's a topic of study here, but just to mention briefly, we can have injury to peripheral nerves so that we can develop neuritis or changes in nerve conduction peripherally. We can develop neuroma, sometimes self-sustaining, so that we have short circuits of a sort in the peripheral nerves that can continue to signal pain. At the level of the spinal cord, we can have hypersensitization, facilitation of incoming pain signals, both signals that started out as pain, but sometimes we can have the secondary hypersensitization such that we get non-painful stimuli which are transmitted as pain. And then on up to the brain where similar mechanisms can happen because of changes in the brain. So it's a very complex system. Normal physiologic signals from the periphery that can be changed in transduction, transmission, or onto the level of perception by both physical and psychological things. And then within the nervous system itself, we can have processes that facilitate, increase, or decrease that pain signal. Now, sometimes the cause of pain is pretty obvious. We see this gentleman who had jumped off. He was a builder who jumped off some scaffolding onto a pile of construction debris, and he got a 6-inch nail through his boot behind the protective heel plate. And he was taken kicking and screaming to the emergency room. When they tried to pull it out, he was in so much pain that they weren't able to pull it out. They had to sedate him with fentanyl, which is a potent opioid, many of you may know, and midazolam, which is a sedating benzodiazepine. They got him really calmed down and his pain under control. And then they pulled the nail out, and it's not going to tell you. Lo and behold, what they found was it had gone between his great toe and his second digit. So he experienced pain, and at the level of perception, I don't doubt that it was exactly as if he had had a knife or a nail go through his foot. But it certainly wasn't the tissue injury that was provoking that pain. So we see this all the time, people with minimum pathology and reports of very severe pain, and people with lots of pathology with very little pain. And here's an example of the latter. Henry Knowles Beecher was an anesthesiologist and surgeon at Harvard back in the 50s and 60s, and many people consider him one of the founding fathers of the pain field, and he did a lot of research on placebo effect. And he had started out as a medic in the streets of Boston in the early 1940s. He saw a lot of motor vehicle accidents and people in pain, and he treated the pain with morphine. Then he went to World War II, and he was at Anzio beachhead, which was similar to Normandy, except it was in Italy earlier in the war. So the GIs were coming onto the beaches. Many of them were severely wounded, and he was on the beach trying to treat people and above all, at that point, give them morphine so they wouldn't suffer. And then he followed them back through the ambulance into the operating theater and into recovery, and to the point that they were shipped home. But his observation was that 75% of the people that he followed, whether it was on the beach or once they were in the hospital, post-surgical, 75% of people said they didn't need any morphine. They didn't have any pain. And he was fascinated by that. And he went back after, he interviewed people while they were there, and then even back in the States, he tracked people down. And what he found is that their wounds meant one thing to them. It meant that they were out of the battle and they were going home. They were alive, they weren't going to die, they were out of the battle and they were going home. And so he got fascinated with the fact that the brain could alter the perception of pain. There have been numbers of studies looking at the relationship between pathology and pain. And this is one study done in 1994, and it looked at 100 people who had no low back pain. And it did MRIs on all of them, and you can see the distribution of people in their 20s, 30s, 40s, 50s, and 60s. And it found that there were significant abnormalities by the time you got to 40 in over 60% of people. But these were people who had no pain. So it's just an example of the fact that pathology can exist and not cause pain, and there can, so that if we are going to do procedures, surgeries,
interventions, sometimes they're clear indications. And usually in pain, we intervene when there's potential for harm. So when we're talking about low back pain, somebody with a small disc that may heal itself, that may be abutting a nerve causing some pain, if it's only sensory, the body may resorb it over time, and we don't necessarily rush to surgery. But there's a wide diversity of practice across the country, and some people say all healthcare is regional, and it's true. I work in both Connecticut and in New Hampshire, and New Hampshire, very few people who presented with a small disc and radicular pain without any kind of signs of motor or bowel or bladder dysfunction would get surgery. In Connecticut, most of them would get not only decompression, but they'd probably get rods and screws and fusion to prevent more pain from other discs that were vulnerable. So it's very variable. And so I would encourage everybody to really look at the literature, particularly before we do irreversible things to patients, because often there are more conservative things that we can do. But anyway, so to sum up this section, physiologic stimulus, it may be nociceptive, which is the name for tissue-driven pain, affecting receptors and starting the pain, stimulating the pain pathways, or it may be neuropathic. There is some evidence that untreated nociceptive pain can lead to hypersensitization and amplification of pain, or a form of neuropathic pain. Often it's both in chronic pain. People often have elements of tissue pathology stimulating their pain and nerves. But whatever that physiologic stimulus, it is filtered through the biopsychosocial context of that individual to their experience of pain. And we need to take it seriously, because pain is pain. Whether you suspect that it may be being driven by PTSD, which we see a lot. There's a high prevalence of PTSD in people who have chronic pain, and I worked in the VA for a long period of time, and many people I treated had terrible combat trauma and physical injuries due to combat, but they also had PTSD and flashbacks and a lot of anxiety and fear, and sometimes they would say, you know, I can't really tell where my PTSD ends and my pain begins. One exacerbates the other. So whatever is filtered through the biopsychosocial context of the day, of the individual on any given day. So we know that, somebody with a stable chronic pain condition, they have severe arthritis, they may have muscle spasm, that one day they may not notice the pain, the next day it'll be worse. So what are the biopsychosocial factors that influence it? Certainly we know that pressure gradients in the atmosphere can sometimes change the experience of pain. A lot of people with arthritis will tell you when the rain is coming. Having a tense relationship with a family member can ramp up pain. Feeling happy and in love may be a distractor, and we'll look at some studies of how these things really affect pain. But once pain persists for a prolonged period of time, it inevitably has a cascade effect on many different features of a patient's life. If you think about when you've had pain, it's really difficult to get comfortable and sleep, so you may get very fatigued. That fatigue makes you less tolerant of the pain. People often get functional disabilities. Their relationships change, they can't work in the same way, they can't do the sports that they previously enjoyed, and they get frustrated and withdrawn as a result. They may have increased stressors of various types in relationships, financial stresses. They begin to think about themselves differently, get cognitive distortions about their value and their role in their relationships, relationship to work or studies or other things. Anxiety and depression are very common. And one physical problem, such as if you have a painful ankle and you're constantly walking with a limp, can lead to an altered gait, which can lead to changes in joints or spasm in the back, which can lead to back pain. And then if you're clenching and guarding all the time, you can eventually get headaches from your clenching of your jaw and your clenching of shoulder muscles. So it's often like peeling an onion when we see people in a pain clinic, that it's not only the original cause of pain, but secondary physiologic problems. They're not sleeping well, they're anxious, depressed, their work is in jeopardy, and you really need to address the whole person, both the physical problems and the other problems. Substance misuse can become a problem for some people. If pain isn't adequately treated or they don't have the tools to manage the pain, it's very natural for people to begin drinking a little more. Alcohol is widely available, which may be somewhat helpful for some people on a short-term basis. It doesn't usually resolve the problem, but for people who are prone to developing substance use disorders, can lead to addiction. And certainly that's true with prescribing of opioids. So I just want to say in here that there are many, many reasons that people who have pain may use substances. Some of them will try and self-treat pain that's under-medicated and try and keep a control on it, but sometimes it can lead to an escalating cycle of use. Many people will find that it's helpful for their pain, but they also notice they slept a little better if they took their opioid, or their mood was actually a little bit better. So when they're not having pain one day, they may pick it up and start self-medicating other symptoms with it. And that can just lead to a vicious cycle of use with higher and higher doses, and in the end is often self-defeating. So self-medication is another reason. We have to be careful in communicating with patients because misunderstandings occur. Very often I'll see physicians write for, the bottle for, say, Percocet after say you have a tib-fib fracture and somebody's on Percocet for a few days, they'll write in it 1 to 2 PO, Q4 to 6 HPRN. So that would allow you, if you do the math, to take up to 12 tablets a day. But then they hand it to the patient, they write for maybe 28 tablets for a week and say, I don't want you to take more than 4 of these a day. And so I'm talking about this because that person might, if they went to the ER, be labeled as misusing, or if they've come back when in fact they're just doing what was said on the bottle. So misunderstanding is a reason. Some people like to get high and they'll use it, or they'll trade it with friends and use it for reward or euphoria, but that in vulnerable people can of course lead to addiction, and we'll talk more about that. And then diversion for profit is something we always have to be aware of, that some people, pain is a perception, it's subjective, we don't have any great ways of measuring it. We try our 0 to 10 and describe the pain, but we really can't be in somebody else's body to know what their pain is. So it is possible for people to get medications purely for sale. I wanted to point out that when people do develop the disease of addiction, it looks an awful lot like the disease of pain, with sleep disturbance, mood disturbance, functional disabilities, loss of increased stress, and many losses. And so when we have the two of them together, and this is why I really emphasize the importance of learning about pain, learning about addiction, because when they occur together, you can't really treat the pain adequately without addressing the substance use disorder. And if somebody has an addiction, you really can't treat that without helping them address their pain more effectively. So they're kind of reinforcing problems. So let's talk about self-management. First, what tools do we have to treat pain? I, as a pain specialist, very methodically, every time I see a patient who has pain, needs treatment, think in these 3 categories. So the first, and depending upon the context of the pain, if you're in an emergency room and somebody has an acute injury, it's probably pretty natural to go to the medications and give them if they're, have several fractures and they're in severe pain. Using an opioid is entirely appropriate as a first-line agent. In other contexts, it may be other approaches that are more appropriate. So, but even in those acute pain settings, looking at each of these categories and seeing what might be helpful is important. So I think very methodically, okay, would a medication help here? Physical interventions. So physical interventions include exercise, but they also include things like heat, cold, pillows, positioning, body positioning, braces, splints, shoe lifts, manual therapies, pressure points, all those tools. What might be helpful? So somebody's in the ER and they require opioids, but a pillow can go a long way if they're malpositioned in a way that's pressing on an injury, just thinking about how can I make the individual more comfortable. Procedures can be very, very helpful. We know that in the acute pain setting, but also in the chronic pain setting, and that's really beyond my talk today, but for example, somebody with rib fractures, intercostal nerve blocks are extremely potent, and people may never need an opioid if you put in a long-acting rib fracture, because usually you only need medications for the first couple of days. And then once the acute pain is passed, it's not as bad. So thinking about procedures for acute pain or chronic pain, and then psychobehavioral interventions. People who are in pain are often very frightened. Just paying attention to the breath, or we know that when you take a slow, long, deep breath that lowers your diaphragm, you're creating a parasympathetic response, which is a relaxation response. And we know that when people are frightened in the emergency room or in a post-operative setting or preoperative setting, that implementation of a breathing exercise or a focus on something that distracts them can be very, very helpful. I used to put earphones on people when they were going into the operating room if they liked music and they were interested in it. And nobody was doing it at that time, and we just laugh, but it really made a difference in people. Distraction can really be a huge difference. So that's pain treatment, the four contexts that I think about, and you may wonder where certain things fall. I don't think I have acupuncture on there. I would probably put that on a physical intervention because it is a needle. It probably stimulates electrical change of some sort, but there are some things that aren't on there. When we're dealing with chronic pain treatment, self-care and clinical care can be very important, and we have goals both to reduce pain, but also to restore function. So when people, I showed that paradigm of chronic pain where there's sleep disturbance, anxiety, functional disability. People often get into patterns where they're isolated, they're inactive, they're physically deconditioned. So it's as important in the chronic pain context to address the pain. Yes, we hope that that can be brought down, but as importantly to restore function and get people back engaged with valued activities and improving their quality of life and their sense of well-being. And that's often a partnership. I'm going to go into these a little more. So chronic care model, you probably will study in clinical years, and I'm not going to go fully into it now, but just to point out that more and more we're appreciating that for all chronic illnesses, whether we're talking about diabetes or hypertension, cardiovascular disease, that engaging the patient in an active role of self-care is really important. So diet and exercise and stress management are important for many chronic diseases that we think of being physical diseases, but all the more so for chronic pain and for substance use disorders. If you think about recovery from substance use disorders, AA and NA are the tried and true long-term and very evidence-based now. I mean, after the fact, they became evidence-based as really making a difference in people's lives. And so self-management is a very important part of all chronic disease management. But when people have chronic pain, we often find that we use an acute pain paradigm. We think that there's a tissue injury here and we have to eradicate the pain generator. If we could just eradicate the pain generator, everything else would get better. There is some truth in that. If we can fully take away the pain, slowly we could get people moving again, normalize the anxiety, treat the depression, probably more easily than when the pain is persistent. But for many people, we can't eradicate the pain generator. And what happens is people go from physician to physical therapist to interventionalist, trying to find a solution for pain. And that can go on for years and years. In the meantime, people often aren't engaged in their life. So we'd like to eradicate the pain generator when it's possible, and we'd like to cover up the pain or reduce the pain when it's possible if medications or blocks or things lower the level of pain. But in the meantime, thinking about engaging somebody in recovery from their chronic pain. So are they doing things that can help with life despite some residual pain? So pain self-management I've talked about as being important both for chronic pain, and I gave you some examples where it can be useful in acute pain in the operating room or in the emergency room. It allows somebody to have an active role. It makes and which is particularly important in people with chronic pain who become increasingly inactive. It reduces their sense of dependency on other people, and that's a real challenge for people with chronic pain. They've often fallen into a pattern where other people are taking care of them, and there are usually ways that they can be empowered and more engaged in their lives. And so this approach pays attention to the biopsychosocial needs of the patient. So the key strategies that we have for treating chronic pain in this manner in self-management are cognitive behavioral interventions. Meditation and or deep relaxation, I'll talk a bit more about. That's usually included in cognitive behavioral therapy, but there's an evidence base in neurobiologic research that is so strong for independent effects of meditation that I'm pulling it out here, and I'll talk a little more about it. And then there's engagement or distraction, two sides of the same thing, distracting yourself from the pain or engaging in something that's important to you. Exercise and group processing. So those are key self-management strategies for chronic pain, but for substance use and mental health disorders, all of these have emerging evidence. So that when somebody, we know about group processing, I mentioned A and NA, which have been around forever. CBT is also, if you're going to have psychotherapy for substance use disorders, cognitive behavioral therapy is the tried and true one. Something newer called acceptance and commitment therapy is evolving out of that. But there's a body of evidence for meditation reducing craving and preventing relapse. Similarly, we know being engaged in activity, and then exercise. There's an emerging body of evidence for exercise as being preventive of craving and relapse and addiction as well. So just very briefly, you'll get more of these in your psychiatry classes or psychology. You may know them anyway. You may get them early on. I'm not sure how it works here. But the idea behind cognitive behavioral interventions is that for all of us, our thoughts, feelings, and behaviors are interconnected. And so some of the common kinds of challenges that pain patients will have is they'll have a thought, I can't handle the pain. And so what does that do? That makes them feel very anxious and very panicky. They get sympathetic nervous system arousal, which can facilitate pain, and they get muscular tension, which can also facilitate pain. So they end up with increased pain. Sometimes they'll feel, if I move, I'm going to hurt, and that's happened in the past. So they stop moving. They feel very paralyzed. They get more disengaged. They feel increasingly depressed, and they get deconditioned. They may get more muscle spasm as a result of deconditioning, and that leads to more pain. No one cares about me, no one can fix me. When you encounter patients with chronic pain, you may find that they often feel very edgy and very irritable and angry, and nobody has been able to help them. So anger is there. There's also a fear of what further losses they'll have. Again, muscle tension and irritability can lead to more pain. And so when we approach somebody in cognitive behavioral therapy, we try and develop small goals. We try and address negative thoughts, and knowing that it may be harder to get at feelings, but if we change behaviors or we practice new ways of thinking about pain. And so instead of saying, I can't move, if I move I'll hurt more, thinking about the ways an individual can move and demonstrating to them through PT and movement exercises that they can begin to move more. They just need to start differently and not do it all at once. So addressing one or more can change the whole cognitive behavioral environment, one or more area, thoughts or feelings or cognitions. So meditation and relaxation have been part of chronic pain treatment probably for millennia, but I only know as far back as the 70s when insurance companies actually would pay for multidisciplinary pain management, and even back in the 1970s, deep relaxation was built in. There are a number of different approaches that have been used to create a deeply relaxed state. Progressive muscle tension, where people clench and relax different parts of their body, and the contrast between the clenching and the relaxing creates a sense of relaxation. Autogenic training is really a form of guided imagery, but it had the name autogenic training. It's really closing your eyes and thinking about your body. Different parts of the body become progressively warmer and heavier and creates a relaxation response. Hypnosis can either be auto-hypnosis or induced by another person. It's not widely used in pain because we spend a lot of time trying to engage people in a sense of self-efficacy that they can do for themselves. So having another person make suggestions about relaxation, some people think is counterproductive, but it is another form of deep relaxation. Guided imagery, often, I mentioned autogenic training, but taking people to having them close their eyes and imagine being in a place where they feel safe, where they feel relaxed, listening to waves lapping on the shore, or the rustle of breeze in the leaves, that sort of thing can help create this state. More and more, though, research is being done specifically on different types of meditation. And at this point in time, mindfulness meditation is getting a lot of attention in the neurobiology literature. And there's a big debate within the field whether mindfulness and mantra-based meditation are the same or different physiologic states. Mantra-based meditation is typified by transcendental meditation, where people have a mantra that's repeated in concert with the breath. I see people, older people nodding in the room. Many of you younger students may not have been exposed to transcendental meditation, but it was big in the 60s and 70s. Anyway, two different paradigms, but meditation, I'm going to show you just one study. So this is a study where 15 subjects who did not have pain were subjected to severe experimental pain. Didn't harm their tissues, but it's very painful. And the paradigm is called cold pressor pain. So you take a bucket of ice water, you put a limb in the ice water until people can't stand it anymore, and you ask them to rate their pain. And in this study, they asked them to rate their pain and the unpleasantness of the pain. And at the same time, they had them lying on a gurney in an MRI, and a functional MRI, and they looked at different parts of their brain to see how they laid up. Okay, so that was the paradigm. They did that before they had any training in meditation. Then they had them come back 4 consecutive days, and they had 20 minutes of guided meditation practice using mindfulness meditation. They didn't have to practice it at home. They didn't have to do anything more. And I like this study because it's really limited intervention. And so what you see, I'm just going to show you a couple of bars. Then they brought them back on the next day, and they had them go into the meditative state. They put their hands in the cold water, their limb in the cold water, and then asked them at the peak of it to rate their pain, the unpleasantness of the pain, and they looked at their brains. And so what you see here, if you just look at the first one, this is visual analog scale ratings of pain. So we went from the first bar with no training, just resting before they were taught meditation, and then at the end. So there was a very significant reduction in pain, but an even more dramatic reduction here from prior to learning meditation to actively practicing meditation in the unpleasantness of pain. So a significant difference. But what's most interesting probably is here's the somatosensory cortex, which is the perceptual area of pain, and looking at with rest prior to being trained in meditation, cold ice water, with meditation, it doesn't even light up. And there are many, many, many other studies looking at different pain-related parts of the brain that suggest similar findings. So something's happening here, and you almost have to ask. But people will say, well, I didn't have my pain when I was meditating, I just didn't notice it. But is the pain if it's not there in a functional MRI? It's just sort of an interesting question. So this is a similar study of engagement or distraction, and this is a very different paradigm. At the University of Washington, they have a big virtual reality lab where they study a lot of conditions, including pain. And in this one, they took burn patients who, as you're probably aware, changing burn bandages is about as painful a clinical thing that we do to patients, and usually they require fairly high doses of opioids, and they hurt while it's being done. And so what they did is put them in a virtual reality state with goggles and headphones and blew a little bit of cold air on them, and it was an image of an icy river, and they were going down and there were icicles pinging, and anyway, they had to manipulate some objects or their boat as they were going down. So they were completely engrossed in this. And then they had them rate their pain. They looked at the amount of morphine that was given them, and then they looked at their brains, again with functional MRIs. And what they found is up to a 50% reduction in pain during debridement using less opioid. And I apologize, the paper didn't report the amount of difference in opioid, which isn't good, but they made the statement that they required less opioid. But here we're looking at the insula and the thalamus, which are other pain relays in the brain, and with their focus on pain, just having the burn changed, you see a lot of metabolic activity there. And here, when they're engaged and distracted, almost none. So again, this is why when our patients are undergoing procedures or have chronic pain, we don't like to see people focused on what's being done to them, or in the case of chronic pain patients, home doing nothing. Because if you have absolutely nothing to do, what gets your attention? Whatever's hurting. So that's just some of the physiologic basis of that. Group support we've known is really important. I mentioned for substance use disorder, now there are groups to support patients with chronic pain. You can find them through the American Chronic Pain Association. There's also now a Chronic Pain Anonymous, which is based on AA and NA. And both of them have very robust websites. So if you, and the benefits really for pain patients is knowing that they're not alone, knowing that other people have been through very similar things. Because often in a community, you know, you don't run into people with severe chronic pain that often. And so I find my patients just are amazed once they can share their stories with other people and get good support from them. These two organizations are very positive in their orientation. Sometimes online self-help groups can end up being more destructive because people get into really negative patterns of thinking and blaming, but I would recommend these two. You can find disease-specific support groups for fibromyalgia or Ehlers-Danlos syndromes or other types of things that some people with pain will have. And then for people with needing recovery supports, there's certainly recovery groups. What time is it? I just want, oh, it's right there. Okay, so I'm going to speed up a little bit. Exercise, just to say in pain, there are many different mechanisms, and this is an osteopathic school, hooray. So you know probably a lot more about movement than I was ever trained in. But, you know, improving joint movement, improving conditioning, reducing spasm, possibly reducing endorphins, which can really be helpful with pain. But we have to be careful in exercising people with chronic pain, because if you make the pain worse, you develop the secondary cycle of splinting and guarding and more pain. So usually we'll start working with people doing something that they're comfortable with, even if it's completely away from the part of their body that's hurting, or just working within their limits of comfort. We throw no pain, no gain out the window when we're treating with people with chronic pain. It's work within your limits of comfort, sort of a yoga type model for doing that. We know that movement and exercise are valuable in other ways. They reduce depression, they improve cognitive function, make people feel better about themselves and more empowered. They reduce stress reactivity, and for people with substance use disorders, relapse and craving are reduced. So what are our roles in treating chronic pain? Well, helping people find the right treatments, and there certainly is a role. I'm emphasizing self-management here. I'm an anesthesiologist. I know there's a role for blocks. I know that there's a role for different implanted stimulators and different types of things. But my expectation is, and there aren't good studies on these, but it's my experience, is that if people are engaged in self-management, everything works better. If you give them a medication, they need less and it works better. If you do an injection, if you think about it, if you do a trigger point injection because somebody has muscle spasm, but they're really, really stressed and they're deconditioned, and you relieve their muscle spasm with putting a little lidocaine in their muscles, it relaxes them. But then they get stressed after it wears off, and their muscles are deconditioned, so they tend to go into spasm more. So, and same thing for an epidural. Epidural injections are used for discs. Putting steroid near an inflamed disc can be very, very helpful. But if somebody is deconditioned, their posture is poor, they're bending and lifting without using proper dynamics, they're going to bring that back. So engaging in self-management as you partner with them can be, on other active strategies, can be very helpful. Just to mention that I mentioned earlier that I work in a chronic pain center, and we have the luxury of bringing people into a residential setting and immersing them in these things. But it can be done in an outpatient setting if people create liaisons with the different providers and identify, those of you in primary care practice particularly, when you go into it, finding gyms, finding mindfulness-based stress reduction class, engaging patients with support groups. And I have a checklist I can make available for clinicians to track chronic pain engagement. There are also technologies out there that are emerging for online CBT, which are just as good as one-to-one CBT, much to the chagrin of many therapists. There are ways of texting people and giving them prompts to how are you sitting, or, you know, different technologies that are emerging and increasingly available. I just to show the outcomes, I don't want to dwell on this, but this is our first, I think, 122 patients who we were able to get data on at the beginning of treatment and after treatment. And blue is pain going down, pain interference with enjoyment of life, interference with activity, anxiety, depression. When you engage somebody in self-care, these are people who were often had substance use and mental health problems as well as chronic pain. And I didn't show, oh yes, these results are at the same time engaging people in self-management, at the same time we're taking them off of opioids. So people, many of whom were on hundreds of milligrams a day, we were able to get 63% of people off of opioids between admission and discharge. And we have limited data on 6 months later, but those who come off seem to be able to stay off, and there's literature elsewhere. 18% of them, though, who had co-occurring opioid misuse and pain, needed to go on to opioid agonist therapy, buprenorphine or Suboxone treatment for an addiction. And then some stayed on lower doses of opioids and did well. So it can be done. It's harder to develop treatment models in the periphery. So I'm going to do a brief update on opioids. You may be aware, and just to remind ourselves that opioids do not equal pain treatment. I think there was a period of time over the last decade and a half where if somebody had pain, particularly chronic pain, we said, oh, we'll give them an opioid, see if we can make the pain go away. Opioids have often been a first-line treatment for acute pain, which is short-lived and going to go away in a few days. And I think most people would agree that's appropriate, unless ice and massage or something do the same thing. A non-steroidal anti-inflammatory and ice do the same, are as effective. And for some things like dental pain, usually ice and ibuprofen are more effective than an opioid in most studies I've seen. But often opioids are indicated. That's not really where the challenge has been. It actually is part of the challenge because there's a question about giving people 60 after a surgery, sending them home with 60 Percocet, and most people find that they only need them for a couple of days, and then there may be 40 or 50 tablets in the medicine cabinet, and so that can be a problem. But just to say that we have all these other tools, and I'm going to skip this, some wonderful quotes about opioids as the joy plant being the most beneficent medication we've ever had, and then some doctors saying that, and then others saying, save our people from the clutches of this hydra-headed monster that stalks the civilized world and wrecks happy homes, fills our jails. That was from the first part of the last century when there was the first American opioid epidemic. So ours is not unique. Even in the 1940s, though, there were people who were discouraging the use of opioids for the treatment of cancer because of the risks of addiction. So we've been going back and forth on these. It's great medication, poor medication. What we know is that in the last decade, so this is between 1999 and 2010, if we look at the green here, we didn't prescribe opioids much through the 20th centuries. They really were discouraged. As I said, in the 1940s, Journal of the American Medical Society was saying, you don't use them in cancer unless you can't possibly not use them because they're too dangerous. So we started in the 1970s to find that, rediscover opioids. And then by the 1980s and 90s, they were being used pretty widely. And what we saw is as marketing continued, through the first 10 years of this century, sales went up, but unfortunately in the purple, deaths also went up in parallel, and the demand for treatment of opioid addiction in orange went up at about the same rate. So we conclude that the more opioids that are available for the treatment of pain, if they are not tightly controlled, they're available for diversion and misuse as well. These are Maine overdose deaths. You're probably familiar with these. This is 1997 to 2015, and we see all drug deaths, including things other than opioids. If we look at the red, we see pharmaceutical opioids went up and then seemed to plateau, and then we see heroin, which, as you're probably aware, in the last 5 years has started to increase enormously. This is New Hampshire, just looking at treatment admissions. In the orange is, in the black is for, I couldn't get data for Maine, but New Hampshire I know well. Black is prescription opioids and the orange is heroin. So heroin, I think in both our states has become more of a problem than prescription opioids. And one of the challenges that we're seeing is neonatal opioid exposure. You see here in Maine, same curve as in New Hampshire. It's such that, though, it's amazing to me, this, I don't know if you can see this, it says neonatal abstinence syndrome, what you need to know. To me, it's astounding that we should have this problem so severely in our states that there's a beautiful glossy manual for parents that's been made how to address it, because it's such a common problem. So what's the relationship between prescription opioid use and heroin? There's been a lot said that if doctors hadn't prescribed all the opioids that they prescribed, we wouldn't have an opioid epidemic. And people support that by saying that about 50% of heroin users, 75% of heroin users under 21, 50% of all heroin users report using prescription opioids prior to using heroin. So prescription opioids led to heroin. There are other people, though, who look at the data and in settings where people come for treatment of opioid use disorder and find that those who are presenting prior to being prescribed prescription opioids had a history of alcohol dependence or marijuana dependence or others. So some will argue that trajectory to addiction is initiated before exposure to the opioids. So I think that's going to be debated for a while. And you have to wonder, with very cheap fentanyl and heroin now in the streets, that is snortable, that you no longer have to cross over to injection in order to use it to get a high. Would people snort heroin in the same way that they have cocaine for years and then become addicted because it tends to be more addicting? And we have to remember that most opioid exposures don't lead to addiction. Tens of thousands of people a day are exposed to opioids for acute pain, and some do become addicted, but a relatively small proportion. And the numbers are really highly debated. The numbers go from 1 in 500 across the general population to 12%, and getting consensus about that is really difficult. So, but what we do know is that most of the opioids that we see come ultimately from most of the prescription opioids when people non-medically use them. This is the National Survey on Drug Use and Health, and they asked people who acknowledged non-medical use of opioids, so they were using them for some other reason, where did you get them? And in the red, what you see is free from a friend or relative, 55%, and another 15 bought or took them for a friend or relative. So really about 75% of people get them from patients who, when you ask them where did your friend or relative get them, 80% get them from one doctor. So most of the, people said, oh, are they robbing pharmacies? Are they robbing manufacturers? Is it trucks being hijacked? It really is coming primarily from prescriptions. So how we prescribe is really important. That said, I just said all the negatives of opioids, they're very important in pain treatment, and we need to learn to balance it because they do relieve pain, they improve function. People get out of hospitals earlier when their pain is treated appropriate, and they can help restore a quality of life. But then that needs to be weighed against these public health effects and the need for people to safeguard their medications, dispose of extra medications, and use them as directed. So there are many, many clinical guidelines that have been made to help us do a better job of prescribing, and I'm just listed there a number of them. Probably the most important for us these days are the Centers for Disease Control guidelines that were released last winter. And what they, I'm going to skip that one and go directly to, well, no, this is sort of the summary of all guidelines, just a high overview, and most of them say pretty much the same thing, and they've often been called universal precautions in opioid therapy. So we know that opioids can heal, but they also can harm. So what do we do to tip the balance in favor of healing? So first step is use opioids and non-opioid components of therapy. As much as non-opioids work, we can use them. Use opioids when they're needed. Assess the risks and benefits in the individual context. Does somebody have a major history of opioid abuse or addiction? Are opioids more of a risk for that person? In which case, maybe we need to go to a more advanced thing, such as a block or a spinal infusion or some other way of controlling pain when we would normally give somebody an opioid. Do we need to help them control if they have a higher risk? Then using informed consent and agreement, making sure that people understand the risks of opioids and that they agree that they are indicated, and then what is expected in terms of renewing prescriptions, using other substances, etc. Initiating a trial with clear goals, not only pain goals, but functional goals, and titrating to low or moderate doses. What we found over time is that high doses not only put people at much higher risk of overdose, but they also seem to be more associated with rapid development of tolerance, so the drugs work less, the development of opioid-induced hyperalgesia, so people actually have more pain. Some people, it's not fully understood in who it's going to occur, but more pain as a result of using the opioids. As I said, more risk of overdose. And then monitoring patients very, very carefully and using objective criteria for monitoring, not just how are you doing, how's your pain control, are you doing okay, but urine drug screens to make sure that they're actually using the drug if that can be demonstrated, and that they're not using substances that may be harmful in combination. Whoops, that did itself. And checking the prescription drug monitoring program. Also physical examination to look for signs of IV drug use or other stigmata of substance use. And then adjusting our therapy as indicated and only continuing it if it's helpful for the patient, and initiating an exit strategy if it's not. Fine. And one thing that would be emphasized by all guidelines is that you don't throw the patient out if they're misusing the opioids or they've developed an addiction to the opioids. You stop the opioids, you find as much as you can and work hard to find other ways of treating their pain and continue to care for them, because somebody who's developed an addiction or opioid misuse needs more care, not less care. If you just throw them out into the street, they're either going to use street drugs or they'll find somebody else and they'll be worse off than they were before. So the only things I'm going to point out about the CDC guidelines, you can read them, there are 12 points, is I mentioned that opioid overdose seems to occur more at higher doses, and they encourage using the lowest effective dose and reassessing if you're getting up to 15 morphine equivalents, and I don't know if you've studied what morphine equivalents are yet, but all opioids, whether you're talking about oxycodone or hydrocodone or fentanyl or others, because they all have different potency and use different doses of them, people tend to convert them into what's called their morphine equivalents. So it's a way of making all the drugs the same and thinking about the dosing. So what the CDC said is reassessing if somebody's getting to about 50 milligrams of oral morphine a day, and not going above 90 milligrams if at all unless absolutely well justified. So, and that's because of the breakpoints for opioid overdose. I think many people feel, and these guidelines are for primary care, and so what they would say is if somebody needs higher doses, it's time to get somebody who's very experienced in opioid therapy involved. They emphasize using a short course, and essentially they're pretty much what I showed you before. They do ask that we consider the use of naloxone, which is, as you know, an opioid antagonist. It can reverse opioid overdoses. And there's a real push now for all patients who are using opioids to have naloxone available, or Narcan or naloxone available in their home. And the reason for that, if you think about it, is they may be on a low dose, but if they have a baby or somebody comes and is suicidal and takes the whole bottle and they're in their house, some people say, just like people with diabetes should have glucose available, if they don't have juice, they should have glucose tablets. Let's make naloxone available for all people wherever there are opioids. And then emphasizing not using concurrent benzodiazepines because many of the overdoses which occur are due to a combination of them. So I should probably end there. I was going to talk about herbal cannabis. I can do that for 5 or 10 minutes if people would like to hear about it, and let people leave if you don't want to hear about it. But I know cannabis is big in Maine now. What would you like me to do? What? I'll give 5 minutes on it. Okay, and feel free to just walk out. But herbal cannabis, it is here. You have become a blue state, and a blue state is a state for which it is legal. I don't know that it's actually been implemented yet, or has it? What? Yes, it has. Okay. So cannabis is here. Previously, you had medical marijuana. We look at the light gray states have allow marijuana for medicinal purposes. The blue, it's have both medicinal and recreational cannabis. Just to say that states vary differently, you know that, but in medical cannabis, some states allow growing, some states don't. New Hampshire doesn't allow growing. I know Maine does allow growing. The amount that you can possess, it's different in every state. So it's important if you're practicing and counseling people on cannabis for clinical purposes that you know the rules of your state. Though I guess when it's legal, it's less important because they can do what they want. It does remain Schedule 1. You know that all controlled substances are Schedule 1 through Schedule 5. Schedule 1 is considered the highest risk, and they're not available for medical use. So under federal law, Cannabis is still illegal for clinical use and for recreational use. Now, Eric Holder, who was one of Obama's attorney generals, made the statement, and he published it in the Federal Record, that he would not, their department, the Department of Justice, would not prosecute people who were using marijuana according to their state laws. So if it's recreational, you can use it. If it's medicinal, you can use it according to your state laws. And then he said, unless you grow it on federal lands, or you shouldn't go in federal parks and smoke it, but you can use it according to federal law. And that was extended through 2016. We have a very different administration, if no one's noticed. And it's not clear how they are going to act on this. And in fact, there have been some rumblings about holding people to the federal law. We don't think that that's going to happen, but I think people who are engaged in certifying patients for the use of cannabis in clinical settings are holding their breath to see what's going to happen. Now, in no state does a physician prescribe marijuana. It's important to understand that. In all states, there's slightly different systems, but you generally certify a patient as having a condition. And so you're not prescribing it because it's not an FDA-approved substance. So a patient has a condition, you attest to their condition. You can even counsel them that you don't think marijuana is going to be good for them, but if they ask you for the certification, you make a judgment whether they can be on their own with this. And then they're enabled to use it. I'm not going to do that there. Marijuana plants, I was just going to point out that a marijuana plant is not a small thing, but they can grow to very big sizes. So if you're allowed to have 2 marijuana plants for personal use, they can still be sold for use by others. I'm going to skip that. It's important to know that there are 2 FDA-approved medications that can legally be prescribed. One is nabilone or Succinate, the other is dronabinol or marijuana. They are both analogs of tetrahydrocannabinol, which is the THC that is usually valued for its recreational use. It also appears to have some analgesic effects. But these drugs are approved for chemotherapy-induced nausea and vomiting, and for HIV-related loss of appetite, for appetite stimulation. However, and so they can be prescribed on a prescription pad. It's not like whole plant cannabis. They can be prescribed. It's also legal to use any drug off-label for other indications. So some people are prescribing these off-label for the use of pain, and there's studies looking at them in other countries for pain, and they seem to be effective for some people for some conditions. But there's a lot of first-pass metabolism as it gets absorbed into the bloodstream and goes through the liver, so it's not as bioavailable as when the cannabis is used in other forms. But you can dose titrate. In phase 3 trials in this country, meaning that the FDA is still studying it, but it's in late phase and there may be brought to market soon, are nabiximols, or it's also called Sativex. And what this is a 50-50 mixture of THC, tetrahydrocannabinol, and CBD, which is cannabidiol. And cannabidiol is a cannabinoid that appears to have some anxiolytic effects. It may attenuate to some degree the high in THC. So Sativex is available in Canada and it is available in Europe. And it has an indication for pain. Some studies suggest it's effective. There are also phase 3 trials going on for something called Epidiolex, which is a new drug that is pure CBD and cannabidiol, and it is going to have an indication for childhood seizures. There's some evidence that CBD may be helpful for anxiety, particularly for post-traumatic stress disorder. But what's happening now is that herbal cannabis has over 70 cannabinoids. We know about THC, we know about CBD. There's 70 or more other cannabinoids in it that all have variable actions. And so it's not a pure pharmaceutical, it's an herb. And as an herbal remedy, certainly may have therapeutic effects for some people. But there's no federal oversight for the content of cannabis. Now, every state is struggling to try and oversee that the growers and the dispensaries who are claiming it has X percent of CBD and X percent of THC and X percent of other cannabinoids are appropriately labeling it. But most people don't have the funding to do that. So unlike the pharmaceutical industry where we have the FDA overseeing things and even then being stressed to do a good job, there is no oversight of herbal cannabis. So one caveat is that fortunately, we certainly don't see overdose deaths with cannabis. It's reportable if it's not combined with other things. So it doesn't have the overdose risks of opioids. So maybe safer for this type of experimentation. But it really is experimentation when people go to a dispensary and are given something because they can't be sure what they're getting. And our understanding of the actions of the different strains is really evolving. These are some of the things, actions that have been studied, and I included only things for which there is some evidence that there may be some benefit. It doesn't say what strains there may be evidence for, what combinations of cannabinoids, but in some clinical studies, antiemetic and anti-nausea, that's been demonstrated because FDA has approved drugs for that, and appetite stimulants been demonstrated. There are at least 5 randomized clinical trials that have shown analgesic effects, especially for neuropathic pain. So that may be an area where we can develop some good pharmaceuticals out of cannabis. Reduced spasticity, particularly with multiple sclerosis, has some evidence. And again, it's not probably all cannabis, but whatever strain was being studied in that. Anticonvulsant effects, particularly with CBD, anxiolytic effects, anti-anxiety effects. It's vasoactive, and there's some talk about there being a role in migraine, but when I show you the next slide, which is a list of side effects, there are also some concern that we are seeing increasing strokes in young people across the globe and increasing use of cannabis. And there's some concern that there may be vasospasm induced. And the American Stroke Association has said there's enough evidence to really focus on this as an area of research. There are some anti-inflammatory effects, particularly from CBD, GI, antispasmodic effects. Intraocular pressure, we have much more precise meds, and people who are using it for glaucoma, I think, it's a real concern. It's approved for glaucoma in New Hampshire, but I think people, you can lose your eyesight if your glaucoma isn't well controlled, and if you don't know the dosing you're using, precise medications are really important. That's not a subjective thing, that's an objective problem that needs to be well treated. And then there is some literature that suggests that people who use opioids for pain use less when they're using it with cannabis. But you have to be very careful because some people develop opioid use disorders, and if they're vulnerable for that, they're also vulnerable for cannabis use disorders. So some people are taking 2 meds that can put them at risk for substance use disorder. You can't see this, I'm sure, fully, but this is on the left. This is an advertisement from a dispensary in New Hampshire. And essentially what they say is what different cannabinoids, in their view, do. But when I looked up CBNA or CBGA in the medical literature, I can't find the studies. I don't doubt that they have some studies, whether they're in-house studies, what kind of trials they are. I just don't have any information. Maybe it's in the biology literature, but I can't find the studies that justify somebody saying that CBGA is a painkiller and anti-erythemic, analgesic, and then other things being anti-obesity, THCV. Maybe there is that activity, but I don't think we know enough to be making these claims about cannabis as being pharmaceuticals. So they have a list of the cannabinoids, and then they tell you what particular plants that they're going to give you and what their cannabinoid content is. So it's almost like this parallel pharmaceutical industry that's growing up beside, our other pharmaceutical industry. So just to say caution in the claims, there is likely a kernel of truth in a lot of this, but I would just conclude that it hasn't been well studied. And the side effects, we know them mostly from recreational use. We do know about cognitive and perceptual distortions. Everybody knows cannabis changes things. Impairment in work and social performance has been well documented. There is a physiologic dependence and withdrawal syndrome, which is different than addiction as it is with opioids. We have physiologic dependence and withdrawal, and we have addiction. Same thing with cannabinoids. About 9% of regular recreational users develop a cannabis dependence, and the hallmark of that is seeking treatment and being unable to start on your own. So by the time people get into treatment, of these 9% who do develop dependence, most of them, the average number of times they've tried to quit on their own is 5. So. If people start at 13, it's about a 17% addiction rate, age of 13, so the earlier you start, the more likely the risk of addiction. There are neonatal developmental changes that you begin to see at age 18 months or 2 years when mothers have smoked during pregnancy, and then developmental changes in adolescents who are regular smokers, poor cognitive performance. Tachycardia is ubiquitous. I mean, if somebody's under the influence of cannabis, when they get onset of the effects, you will see a rise in pulse rate. It's not usually significant in a young, healthy person, but people with coronary artery disease need to be careful because there's also can be a drop in blood pressure, so the oxygen available to the heart may fall. There's also a risk of falls in elderly people, and I mentioned the risk of myocardial infarctions. COPD and asthma can be exacerbated with smoking, not with oral use. And then this question about cerebrovascular accidents occurring, strokes occurring, that can occur even in young, healthy people, and it's thought to be related to vasospasm. There's a debate about that in the literature. It's not clear that that is an effect, but there's some concern. And then all the public health concerns about driving under the influence and increasing motor vehicle accidents in states where it is widely used. We have to counsel people on delivery systems. Smoke is really rapid in onset, but we have all those hydrocarbons that can exacerbate asthma and COPD. Does not appear to be associated with an increased risk of cancer, though, in heavy users, and that's probably, possibly, because of some anti-neoplastic effects of some cannabinoids. We're not sure. Vaporization, it's heating until the volatile components come out, so not ingesting the smoke, but just the active components. It is also rapid of onset and gets around the products of conduction. Orally consumed, of course, is all oral versus IV. It's slower in onset because it needs to be digested and absorbed into the blood system. And it's more difficult to titrate for people. And then there's the problem, you're looking at those inviting lollipops and Pop-Tarts and other things. We know in Colorado that the number of children taken to the emergency room in stuporous conditions, in comas, has increased rapidly since it was legalized. So I hope that doesn't happen in Maine. It'll be interesting to see. So I was part of a white paper for the American Pain Society on use of clinical cannabis. And essentially what we said is, be aware of the laws that you're working on. You know, advise patients as best you can in the absence of much robust scientific literature. And essentially all this says is treat it the same way you would other controlled substances that you're prescribing. So if you're prescribing opioids, you make sure they understand the risks and benefits. You have an opioid treatment agreement. You use urine drug screens to see if they're slipping into use of other substances that can be harmful to them. And you monitor them carefully. And so just to sum up, if you're treating chronic pain, I would, and even acute pain, engage people in self-management. And then strategic use of other interventions can be very helpful, and thinking about pain, function, and quality of life, not just getting that number. We say 0 to 10. You want to get that number down to 2. You can't always do it, but you can often get people functioning better and really enjoying their lives. So I'm sorry I went over, but I'm happy to stay and take any questions for anyone who would like. Thank you.